Dr. Glass, thank you so much for joining us here on Health Connection. Our topic is mammograms and new technology. We hear a lot of public discussion, a lot in the media about how frequently a woman should have a mammogram. Let's get a definition. What exactly is a mammogram, and how are mammograms used and read by radiologists, and what do they reveal?
So a mammogram is basically just an x-ray of the breast. We do two of each breast. That's considered two-dimensional imaging, and it shows us several things. One is it shows very small calcifications, which we call microcalcifications. Those are typically the earliest sign of ductal carcinoma in situ, of breast cancer. And then also for the women who the cancer is broken out of the duct, where it's become invasive, we can see other manifestations of that as well. So essentially it's a test to detect breast cancer.
A lot lately in the media about how often a woman should have a mammogram. So how often should a woman have a mammogram, and how do those recommendations change as with respect to family history?
So it just depends on which governing body you're looking at. Radiologists go by the American College of Radiology, which recommends that a woman begin having mammograms at the age of 40 and then every year thereafter. If you have a family history, you want to screen 10 years earlier than the youngest relative. So, for example, if your mother had breast cancer at the age of 40, we would start screening at 30.
Okay. Where are we with respect to mammogram technology as compared to 5 or 10 years ago?
So before we only did two-dimensional imaging, which we still do today, but now we also have 3D imaging, which is known as tomosynthesis. And that's where we essentially cut the breast into slices radiographically, and it allows us to see more than we did on the two-dimensional imaging.
Well, amplify on that. With respect to 2D versus 3D, what do we gain?
Sure. So the 2D is, like we talked about, it's just those two radiographs or two mammograms of each breast, whereas 3D, the X-ray camera is actually moving, so it creates almost like individual slices through the breast, so you get much more images, like a stack of images, rather than just plain 2D images.
Okay, and forgive my lay description, it means that where tissue could be obscuring a lesion, you can now see the lesion.
Right, so previously we had a problem with overlapping tissue. It's hard to see through tissue. For example, women with dense breast tissue can have a lot of overlapping tissue, and the 3D does just that. It's sort of, by creating these individual slices, it allows us to better see through the tissue to look for other things.
Okay. UT Health Northeast has breast tomosynthesis, which is the fancy name for 3D mammography, also automated breast ultrasound. So explain, how each works. You've done 3D, but just compare and contrast the two.
Sure. So 3D is still considered mammography, whereas ABIS, which is the automatic breast ultrasound, is done where the patient lays on her back on the table, and then we have a large probe that's placed over each breast, first on one and then on the other, and it's called automated because the transducer essentially scans the entirety of the breast as opposed to someone standing there and holding a probe. And it's another screening exam, one that we use. It's an adjunct, one that we use for women with dense breasts. It does not replace mammography. It's used in addition to, for women who have tissue that we need an additional tool.
Okay. Has newer technology made getting a mammogram or other screening less uncomfortable?
So we wish, right? Unfortunately, no. That's because there are actually regulations in place which say that you have to apply 40 pounds of pressure to each breast during a mammogram. The reason is because that allows the tissue to be thinned out enough that we could actually take the images and see what we need to see. So it's still the same discomfort, unfortunately.
Okay. So after a standard screening mammogram, some women may need further testing. Explain how, in that case, ultrasound is used.
So that wouldn't be the automated breast ultrasound, that would be handheld breast ultrasound. And what happens is when we see something on a mammogram that we're concerned about, we'll call the patient back, and then we'll do probably additional mammographic images as well as potentially a handheld ultrasound. So then she would lay on the table, we have a sonographer come in, look at the exact area that we're concerned about, which just tells us more about the tissue that's there. It's a different modality, so it shows different things. And then depending on what we see, we either decide that it's nothing to be concerned about, or perhaps she may need a biopsy.
These new technologies, have they reduced the instances of what's false positives or need to call a woman back in?
Yes, definitely. So that's a great thing about tomosynthesis. It's definitely been shown to reduce the callback rate because we're able to see the tissue so nicely on each individual slice, we get less of that overlapping tissue, less of what we call like a fake out, that would require us to previously call a woman back and further work that up.
Okay. Another technology, molecular breast imaging, or MBI, as it says here. Another tool that radiologists such as you can use. Explain how MBI helps detect tumors.
So with MBI, we use something called a radioisotope that's injected into the vein. It's the specific one that we use is technetium sestamibi, and that is something that's taken up by tumor cells. So it's non-specific, it's taken up by many different types of tumors, but in the breast, since we're really only looking for breast cancer, it's taken up in the breast. And so we have they're gamma cameras, they're a different type of receptor, but they're cameras that see that radioisotope, and if there's a tumor in the breast that will take up that radioisotope, we then take the pictures, and you'll see the cancer. It essentially lights up on the scan.
Okay. Is it ever too late for a woman to begin having a mammogram if she's just for whatever reason not done it?
So it's never too late. That's a topic that should be discussed with your primary care physician. Some people say if you have less than 10 years of life expectancy, they no longer recommend mammograms. However, it's very much on an individual basis. We see patients that are 88 or 89 years old who we're still screening.
All right. If a woman's about to have her first mammogram, what criteria should she use in selecting where she chooses to have it done?
Yeah, so I think especially in today's age with the internet, there's a lot of reviews that are online, and I think it's good to look at patient reviews before you go, see if people have had a good experience. If they haven't, why? Are their concerns legitimate? Also, one thing that I think that's very important that people don't realize is the medical record is not universal between all hospitals. So I think typically it's good to stay in the same location where you've had your mammograms in the past, because when you frequently switch places, there's no way for us to digitally get those images other than on a CD, and the disc isn't as high quality as what we acquire here. So I typically recommend, unless of course you're moving or you had a bad experience and you want to change, it's typically good to stay in the same place just so that they have the highest quality of images to compare to the years before.
Very well, doctor. Thank you so much for your time.
Thank you so much.